Hello, everyone. Welcome to the webinar, Sickle Cell, What Every Nurse Should Know. My name is Jackie Dover, and I will be facilitating the webinar today. I'm a member of the Peel chapter of RNEO, and I'm currently employed as a public health nurse for Division in Peel. I'd like to thank everyone for logging on. In a moment, I'll introduce our two presenters for today, but first I wish to share with you how we came about doing this particular webinar. I became involved with sickle cell disease advocacy about 4 years ago, inspired and mentored by registered nurse and sickle cell trailblazer, Miss Lily Johnson. With Lily's encouragement and the support of RNEO's Peel chapter, I drafted a resolution on sickle cell and submitted it to RNEO's 2015 AGM. The resolution passed, and this webinar was created as a first step for RNEO to engage with nurses in settings across the province, in all practice settings. So today's webinar will provide an introduction to sickle cell disease and describe the nurse's role in caring for clients with sickle cell. It is now my pleasure to introduce to you our two guest speakers. Our two guest speakers today are Kate Uchendu and Melinda Chung. Kate Uchendu is a nurse practitioner with the Red Blood Cell Disorders Program at Toronto General Hospital. Kate has been a nurse practitioner working with red blood cell disorders for about 4 years. She completed her Bachelor of Science in Nursing, as well as a Master of Nursing Practice, nurse practitioner from the University of Toronto. Melinda Chung is a nurse practitioner that has been with the Sickle Cell and Thalassemia Program at Sick Kids Hospital in Toronto for the past 5 years. She completed her Bachelor of Science in Nursing at Ryerson University and Master of Nursing, nurse practitioner at the University of Toronto. I'd also like to take a moment to thank content contributor Karen Fleming, registered nurse, Master of Nursing. Karen is not on the call today, but she contributed to the webinar content. Karen is a clinical nurse educator, child and teen program, North York General Hospital.
Thank you very much for that kind introduction, Jackie. When we were approached to talk about sickle cell disease, as you can imagine, sickle cell is a disorder with great breadth. It was difficult for us to kind of figure out how to make it focused and be able to have a substantive conversation in 30 to 45 minutes and also provide an opportunity for people to ask questions. So we thought we would look at what sickle cell disease is, look briefly at the epidemiology of sickle cell disease. We'll talk about newborn screening, the multiple clinical manifestations of sickle cell disease, pain in sickle cell disease, which is the most frequent presentation that nurses will encounter, as well as the psychosocial impact of sickle cell disease. But at the end of the day, what this is really about is a call to action for nurses. We believe that registered nurses in the province of Ontario, these are the healthcare providers that we really need to focus on to help us advocate and move the agenda forward for patients with sickle cell disease. So sickle cell disease is a group of inherited red blood cell disorders caused by abnormal hemoglobin. Shortly, we will be looking at a schematic of how sickle cell disease is inherited. But it is important for people to understand that sickle cell disease is not something you contract, as some people think. It's something that you're born with. You inherit it when you have parents who are two healthy carriers of the sickle cell trait. And normal hemoglobin is very different from abnormal hemoglobin. Abnormal hemoglobin, which is the hemoglobin in sickle cell disease, is the result of one substitution of an amino acid that causes the protein, the hemoglobin protein, to behave so differently. And we'll be looking at a schematic shortly. So this is a schematic of how a patient might end up with sickle cell disease. You have a parent who is a heterozygous carrier. So they have one normal hemoglobin, one abnormal. When two people who are like this get married and have a child, with each pregnancy, there's a 25% chance of having a child with sickle cell disease. Now, that means that with each different pregnancy, you have this 25% chance. You can have all children and all of them will have sickle cell, and you could also have all of them and they're all normal. So it's important for nurses to understand how patients come by having sickle cell disease, as we have an important role to play in education and engagement of patients. If you look at the map on the screen, you can see the colors, and the places with the densest incidence of sickle cell disease are in the dark purple color, and you can see in West Africa, you have a very strong concentration of pathological hemoglobin disorders in that area. But you can see across the equator, usually what we call the malaria belt, you can see a higher incidence of hemoglobin disorders along this distribution. Why is this so? Because the sickle hemoglobin is actually thought to confer protection on people against malaria. As you well know, malaria has been endemic in some parts of the world for centuries and has decimated numerous populations. When a patient carries the sickle hemoglobin, they actually don't die off from malaria. And you can understand why it is difficult to eliminate sickle cell disease completely. So when someone who is a carrier of the sickle trait gets married to someone else, then the likelihood of producing a child with sickle cell disease is quite high. And this is why it is so important as patterns of global migration shift, and you have patients migrating to Canada, to North America, from all around the world. It is very important that we're able to screen so that we can identify patients with these disorders.
I'm going to speak a little bit about Ontario newborn screening. So currently through newborn screening, they screen for 26 different diseases, including sickle cell. Sickle cell was added to the newborn screening in November of 2006. Since then, we've been able to identify babies born with sickle cell disease, and this has helped to reduce and prevent the morbidity and mortality related to severe bacterial infections related to sickle cell. So currently, all newborns in Ontario are screened for the following targeted hemoglobin diseases. So this would include hemoglobin SS, SC, and S beta thalassemia. In Toronto, we see approximately 60 cases per year. Each of these positive newborn screens in Ontario are sent to their treatment centers. In Toronto, those cases are referred to Sickle. We see these newborns at approximately 2 to 3 months of age. They're all started on penicillin prophylactically to help lower that risk of contracting pneumococcal bacterial infection. All parents are educated about the genetics of sickle cell disease. We specifically talk about the different signs and symptoms to look out for in their children. And we also offer genetic counseling. So like Kate says, if both parents are trait carriers, there's always that 25% chance of having a child with sickle cell disease. So through offering genetic counseling, you're hoping you can reduce that risk with the next pregnancy. As you can see in this slide that was provided by Ontario Newborn Screening Treatment Center in Ottawa, if you look at the bottom left-hand corner, you can see that in the past 5 years, from 2010 to 2014, there's a little bit less than 100 cases per year that were screened positive for sickle cell disease in Ontario. So like Kate mentioned, sickle cell disease is a red blood cell disorder. So we know that hemoglobin is the molecule that gives our blood that red color, and we know that our red blood cells are made up of hemoglobin. And the main function of hemoglobin is to help transport oxygen to the various parts of our body that need it. When we look at the difference between what a sickled red blood cell is versus a normal red blood cell, we know that a normal red blood cell is dish-shaped, kind of round like a donut, except it doesn't have the hole in it. It's very flexible, it flows very easily through our blood vessels, and it's very well hydrated. A normal red blood cell can last about 110 to 120 days before the body has to make new red blood cells. When you compare this to what a sickled red blood cell looks like, it's obviously sickled shaped. It's very hard, not very flexible, not very well hydrated, and it can sometimes have difficulty flowing through our blood vessels. The sickled red blood cell only lives for about 10 to 20 days before the body has to make new red blood cells, leading to the anemia that is related to sickle cell disease. And if you look at the picture towards the right, you can see the sickled hemoglobin blocking the blood vessels. And this is what initially leads to a lot of the pain that our sickle cell patients experience, which we'll talk about in more detail later. So the effects of these red blood cells sickling obviously lead to a lot of pain, which is the most common presenting defect for many of our patients. It can lead to organ damage and anemia.
As Melina indicated, the main problems associated with sickle cell disease have to do with frequent blockage of vessels, the rapid destruction of the red blood cells, anemia, and damage to organs because of the blockage of those vessels. The clinical manifestations of sickle cell disease are quite diverse, and all the organ systems in the body are affected by sickle cell disease. The eyes, the brain, the kidneys, even the skin. The joints are also affected by sickle cell disease when patients develop a vascular necrosis of the hips. This is due to chronic ischemia of the joints of big bones, eventually leading to these joints collapsing completely. The numerous presentations of sickle cell disease, both in children and adults, involve also infection, destruction of the spleen, as well as something called priapism. And we'll talk a little bit about this in some more detail. Typically, complications of sickle cell disease can present acutely, where the patients come suddenly with acute pain, and over time, pain can also become chronic. Pain, as Melina indicated, is the most frequent presentation of sickle cell disease, and it has been studied extensively in patients with sickle cell disease. Ballas and his group did a lot of work in Atlanta around understanding pain in sickle cell disease, and they concluded that the pain in sickle cell disease proceeds in 4 distinct phases: the prodromal phase, the initial phase, the established phase, and the resolving phase. And for us as healthcare professionals, especially nurses, it's important for us to understand these phases, because if we institute treatments early, the risk of prolonged hospitalization is reduced, and the risk of mortality and morbidity associated with acute sickle cell crisis is greatly reduced. In the prodromal phase, this is the earliest phase. The patients can tell that something is wrong. There's some paresthesia, some numbness, and a few days after that, the acute phase of the acute sickle cell crisis starts, where the pain is rising rapidly. At that time, the patients usually try to manage it at home. If their efforts at home fail, they then present themselves to the emergency department. So as you can imagine, by the time the patients are presenting themselves to the emergency department at your local hospital, they have already exhausted their options at home. During the initial phase, the pain rises steadily, it gets to a peak, high sustained peak, and it stays there for several days. And some of the data is suggesting that this could last as long as 3 to 4 days, and after that, you get into the resolving phase. And there are objective signs of these changes in the patient's hemoglobin count, their retic count, and their leukocytes as well. And patients, as you well know, present acutely, but there can also be a chronic component of the pain. Some of the instances where patients will present with acute pain will be, of course, in the context of a classic vaso-occlusive episode. This is the most frequent presentation we see, where the patients present to the emergency department with pain that starts somewhere and often migrates to other parts of the body. It usually starts at a lower intensity and just gets higher and higher and higher. Cholecystitis, which is gallbladder inflammation, is also a frequent complication of sickle cell disease that will present with acute abdominal pain. The pain might be disseminated initially and then localized later. So it's important to recognize, in addition to classic vaso-occlusive pain, that there are other significant complications that sickle cell can bring about that clinicians have to be aware of. Splenic sequestration is more common in children, but has also occurred in adults. Some of things that can cause chronic pain in patients with sickle cell disease will be leg ulcers. I have seen patients with leg ulcers, some of them taking 5 to 6 years to heal. These ulcers are typically very painful, and they result from initially typically bilateral swelling of the ankle, the skin breaks down, and it becomes extremely difficult to manage. This is extremely painful, and it's important to recognize this as a cause of chronic pain in patients with sickle cell disease. Chronic osteomyelitis can also cause chronic pain, and a vascular necrosis of the hips and shoulders can also cause chronic pain. Typically, patients with a vascular necrosis first present with some non-specific pain, sometimes in the hip, sometimes in the groin, and over time, their gait becomes much more difficult. Eventually, the hip collapses and they actually have to have a hip replacement. Depression and anxiety is another thing that can complicate chronic pain. It is helpful for clinicians to be able to identify when patients are depressed or anxious and provide the supports that are required for the patient. Patients who present with severe pain in sickle cell disease have to be assessed and treatment initiated within 30 minutes. It's also important when patients have other complications to seek the support of hematology. Hematologists are well versed with the management of patients with sickle cell disease, and they might be able to provide other recommendations to support the treatment of patients with sickle cell disease. Also, as patients move from the emergency department to the inpatient area, it is also important to maintain best practices on the inpatient areas for management of patients with sickle cell disease if they are admitted.
So we'll be talking about the 3 Ps. One of the ways that we can help with pain management in patients with sickle cell disease. So the 3 Ps include pharmacological approach. So this is all of your medications. The mainstay medications that we generally use is acetaminophen, ibuprofen, and morphine or hydromorphone. The psychological effects would be obviously educating yourself about pain management and then using distraction with your patients to help ease their mind in regards to the pain that they are feeling. And then the 3rd P is the physical approach. So if you're using heat packs, massage, a warm bath, anything warm to help increase circulation to the area. And for some of those inpatient sickle cell patients, you can hopefully utilize your physiotherapist as well. But you have to remember that even though that you're combining the 3 Ps together, it also helps with pain management. But you have to also remember and remind your patients that it actually doesn't stop the sickling from happening. So one of the ways that you can incorporate your pharmacological choices is using the numerical pain scale with the World Health Organization analgesia ladder. So as you can see on the top, the numerical scale is 0 to 10, 0 being no pain whatsoever, and 10 being the worst pain you've ever felt. So the World Health Organization recommends using a balanced analgesia. So basically using any one of your classes of analgesia with hopes that you have better pain relief with the least amount of side effects. You want to be able to schedule your medication around the clock, usually by mouth, and following the ladder, either going up and down or decreasing and increasing your medication. Some of the treatment options that we do have for sickle cell is bone marrow transplant. It's not something that we do regularly here in Toronto, but other managements that we do use frequently is hydroxyurea. So hydroxyurea is a drug that helps the bone marrow to make more fetal hemoglobin and hopes to reduce the amount of sickling that's happening in the body. And then for some of those patients that have had complications, some of them are put on regular blood transfusions or exchange transfusion programs. So when it comes to blood transfusions, it's an important topic to remember and understand. So with every transfusion for a sickle cell patient, there are obviously phenotypes. You want to know what their red blood cell phenotype is. You want to transfuse blood that has normal hemoglobin. And really the point of transfusion is to hopefully remove the sickle hemoglobin and replace it with normal hemoglobin. We never ever recommend an autologous transfusion. We never ever take a sickle cell patient's blood and transfuse it back to them. And all sickle cell patients are at a high risk for something called alloimmunization. So it's an immune response to the foreign antigens that can be found in blood. So we know that there's an increased incidence with each transfusion that a sickle cell patient has, and that It's in the sickle cell population, they have a higher incidence, the general public, just because of the incompatibility that we find in donor blood versus recipients. So most importantly, when it comes to blood transfusions in the sickle cell population, you should not only let the blood bank know that your patient is a sickle cell patient, but you should also be speaking with a hematologist in regards to if a blood transfusion is even needed. We also want to reinforce that when it comes to the straightforward acute pain that the sickle cell patient could have, transfusion is no longer the go-to to help resolve that episode of pain. Transfusion should be, discussed at length with the hematologist before even being considered.
So just to talk about some of the issues commonly encountered by patients and families with sickle cell disease. What we are told and what is also in the literature is that stigma around sickle cell disease continues to be a problem for our patients. Many patients are not comfortable to share at work that they have sickle cell disease. Poverty is also an issue that we often come across with our patients. Another issue, and this is an area where I believe nurses can really help, is this perception of addiction and chronic pain in our patients. It's really important for us as healthcare providers, when patients present with pain, to help validate that pain and support the patient in the context of the episode that they are currently having. The literature also indicates that racism is an issue in patients with sickle cell disease. Numerous studies have been done to show that patients present with sickle cell to the emergency department and another patient may present with cancer pain. On the pain scale, the patient with sickle cell has a higher pain score, but the pain is not treated as aggressively with the other patient who is suffering from cancer. So it's important for us to really support patients and help them, empathize with them, validate their pain. Also, it's not uncommon for patients to be treated and discharged for a sickle cell pain episode, and within 24 to 48 hours, the patients are back in the hospital. These patients are then sort of labeled frequent flyers, and it inhibits the trusting relationship that patients can have with healthcare providers, and this has been known to cause worse outcomes for our patients. Transitions in care is also another vulnerable period for patients with sickle cell disease as they transition from pediatric to adult care between the ages of 18 to 24. It's important for patients to be encouraged to be connected with either a proper comprehensive sickle cell center or a hematologist in the community. Provider and patient knowledge deficit is also an important part of some of the issues that patients encounter. It's not uncommon for our patients to be asked things like, how did you get sickle cell disease? It's important for us as healthcare providers to understand that this is something genetic patients have inherited, not due to any poor choices that they have made. It's also important for us to engage patients, educate them, and help them really understand the burden of disease that they carry. Some of the psychosocial issues that result from sickle cell disease include impact on relationships. Patients are unable to maintain relationships, sometimes with partners, with family members, and even with peers. They're sometimes not able to keep up. There are constantly issues around workplace and finances. Difficulty with school is also well identified in the literature with patients with sickle cell disease, and it's important for us to be able to empathize, support, but also most importantly, educate. Anxiety around health is another impact that sickle cell can have on patients, and even guilt around passing the disorder to their children or the burden they might have when they get into relationships with others. These things have a profound impact on patients and sometimes can inhibit their ability to engage in meaningful relationships. So what can nurses do? This is a very important part of why we're having this webinar today. We really believe that registered nurses in the province of Ontario really should be at the forefront of advocating for patients with sickle cell disease. So as a nurse, what can you do? You can educate yourself about sickle cell disease, become knowledgeable about what it is, understand that yes, pain is the most frequent way the patient will present, but also understand that stroke can be a complication of sickle cell disease. Priapism can be a complication of sickle cell disease, and it is important for us to assess patients quickly. Timely assessment and institution of pain management protocols. I cannot stress enough the importance of this in raising the patient's confidence in their healthcare team, as well as reducing the anxiety that they have. These things tend to lead to better outcomes, shorter length of stay, and improved outcomes for patients when their pain is treated quickly and effectively. It is also important for patients and healthcare providers to have a trusting relationship. And I cannot stress enough the body language of healthcare providers with patients. You might say something, but your body language is saying something else to the patient. It's important for all of us to pay attention to that. It's also important for us to educate patients to use a proactive approach in pain management. Like I talked about, if a patient is able to institute effective treatment strategies in the prodromal phase of a sickle cell episode, attack it really quickly, this can reduce and even prevent the patient presenting to the emergency department. It's also important for our patients and families to be educated on the importance of transitioning from pediatric care to adult care and understanding that this can be a vulnerable period where the individual is being transitioned from the parent being responsible to the individual being responsible for themselves. This can be a vulnerable period. And in collaboration with the Sick Kids team, we actually have a strong transition program between the Hospital for Sick Children and Toronto General Hospital. But it's important for those who are not necessarily connected to big centers and have hematologists in the community to have that conversation about transition. It's a very important part of care that patients get as they move from pediatrics to becoming a young adult.
What are some of the best practices you could utilize as a nurse when treating sickle cell patients? You can utilize any of the following. You just have to check with your institution. Each institution might be a little bit different in regards to if they have any clinical protocol or clinical best practice guidelines in regards to sickle cell. Whether you're able to utilize medical directives. So I know at Sick Kids in the emergency department, our nurses have medical directives to give acetaminophen. So at least that's one way they can start pain management when any of our patients are seen in the emergency department. They also have pre-printed order sets in regards to fever and pain. So what's going to be the next step? You know, they can kind of utilize these pre-printed order sets to kind of help plan out how they can get pain management initiated within the first 30 minutes of that visit. And then for our inpatient population, they have specific pre-printed order sets. So an example of this is all the order sets have acetaminophen and ibuprofen ordered on it as a scheduled medication instead of a PRN. So you're utilizing the pain medication around the clock and ensuring that that patient is taken care of pain-wise when they are admitted. In regards to some of the advocacy groups, there are many different associations that are in the Greater Toronto area. Some of them are listed on the left side. The Sickle Cell Association Group of Ontario is one of the main organizations that actually provides parental and healthcare education sessions. So it's always great to connect with them to learn more about sickle cell disease for not only your information, but for patient information as well. And then Camp Jamoki is a camp for kids with sickle cell that usually runs 2 weeks within the summer months. And then there's also the Sickle Cell Association of Ontario, and then the Sickle Cell Association of Canada, and then also the International Association of Sickle Cell Nurses and Physician Assistants. To the right side, there's community health organizations. So if you're ever in need of any community health centers that treat a lot of our sickle cell patients, these are just a few that are involved with the cell community. And then we also have the Canadian Hemoglobinopathy Association. So if you're ever interested in learning more about hemoglobinopathy, definitely join Canteen. We also have a nursing group that, you know, around the province we're sharing, you know, different ways we treat our sickle cell patients and any way we can help each other in regards to management of our patients. The resources listed below, you can definitely get more information in regards to the topics that we discussed today. And then really thank you very much for joining the webinar. So sorry for the sound issues. We're happy to take questions now.
So if you have any questions for the presenters, please type them into the chat box on the bottom right corner of the WebEx screen. We received one question from a participant around how to screen pre-admission clinic clients for sickle cell.
So the question that came from a participant was how to screen clinic client for sickle cell. I guess what the person meant was, how do you screen everyone, make sure none of the patients have sickle cell, or what are you going to do? We generally do not recommend screening everyone for sickle cell disease, but for all patients who are coming for pre-admission, everyone is going to get at least a CBC, a complete blood count. Now, if you find an abnormal CBC result, that should then prompt you to investigate further. Most people who have sickle cell disease know that they have, but I have actually come across a 60-year-old patient who was diagnosed with sickle cell disease here in Canada. She had been informed in her country of origin that she had sickle cell traits. So some people may not be aware, it's unlikely, but it's foreseeable that people might not be aware. So what you take away from this, the CBC is the first line of defense. Everyone gets the CBC. If it's abnormal, then you want to look further. And if you want to look further, the test you will then order will be a hemoglobin electrophoresis. A hemoglobin electrophoresis will be able to look at the hemoglobin you have. If you have any abnormal hemoglobin, it will identify it, and it will give you the percentage to which, the percentage of your hemoglobin that is abnormal. So it will break down what percentage of your hemoglobin is normal and what percentage is abnormal.
Are there any other questions?
So the question is, how do you prepare if a patient is going for surgery? For a sickle cell patient going to surgery, really a patient with sickle cell disease should not be sent to the operating room if they have not been seen by a hematologist. So that's point number one. Before a patient with sickle cell disease ends up in the operating room, they must be seen by a hematologist. Why? Most patients with sickle cell disease who need to go for surgery actually need to have an exchange transfusion. And an exchange transfusion is just a procedure where you drain out some of their sickle blood and then replace it with fresh blood to reduce the likelihood that they develop complications post-operatively. But the most important thing, hematology must be consulted before a patient with sickle cell disease is sent to the operating room.
And we have another question. How would you be able to screen for pregnant women who are carriers for sickle cell? And I'm sure this is a question that might be on the mind of many of our participants.
Screen for if anyone is a carrier, regardless if it was a pregnant patient or not. The go-to test would be a hemoglobin analysis, and it just basically breaks down the percentage of hemoglobin S versus normal hemoglobin that a person carries.
Okay, we're going to ask about, what about anesthesiology consultation before surgery?
So absolutely, anesthesia consultation is required before surgery for all patients, especially if they're going to require anesthesia. So yes, anesthesia is absolutely necessary. Anesthesia consultation is absolutely required for all sickle cell patients prior to surgery.
So the next question is if we are looking for hemoglobin S specifically.
And the answer is yes. And we're looking for hemoglobin S in the homozygous state. So if you have a patient where their hemoglobin S is greater than 80%, 90%, most definitely you're dealing with a patient with sickle cell. For patients who have the sickle cell trait, 50% of their hemoglobin will be normal and 50% will be sickle.
So we've had a clarification of a question. and is there anything in particular that operating room nurses need to prepare for?
Well, I don't think there's anything different that you need to prepare for a patient with sickle cell versus any other patient who is going to operating room. For sure, as long as hematology has been consulted, and if hematology has been consulted, most likely the patient would have been pre-transfused prior to surgery and will have blood in case there's a lot of blood loss in the surgery. The blood bank is usually very good about having blood sequestered for patients with sickle cell disease. So nothing specifically that operating room nurses need to prepare differently for, but they just need to make sure patients have been seen by hematology prior to presenting in the operating room. No matter how urgent the surgery is for a patient with sickle cell disease, it is critical that the patient be seen by hematology first.
So we've received another question. How is the racism issue dealt with currently with regards to the pain crisis of sickle cell disease when these patients arrive in the emergency department?
As you can imagine, the issue of racism is a complex issue. And I can tell you that our patients come to us with different stories of how they were treated in different emergency departments. And studies have been done where patients have presented in the emergency department with sickle cell disease, and they're treated differently than patients, for instance, with cancer. What are we currently doing? Well, it's difficult to just go to an emergency department and say the issue is racism. I think what we're trying to do is to create awareness, help people understand, first of all, this is what sickle cell is. This is how painful it can become. I'm not sure it would be helpful to go and say, well, the issue is racism, but I think helping people be aware that there is literature to suggest that racism could be an issue, I think helps move the conversation along. I think another thing that is also important is for patients to know how to advocate for themselves and also how to prepare themselves before they go to the emergency department. So it's a complex issue that doesn't have one solution, but I know that education of patients and education of healthcare providers will really go a long way towards helping patients and providers understand more.
And just to add to that before we move to the next question, glad the question was raised because it does sort of open up a conversation about the role of stigma and discrimination in terms of providing care for people with sickle cell disease. So that's a large conversation that needs to happen as well. So, and just to move on to the next question, since infants are born with fetal hemoglobin F, and will convert then to adult hemoglobin, how long will it take for a child to develop sickle cell enough to cause a crisis?
So in an infant that's born with sickle cell, they have close to about 100% F and a little bit of S hemoglobin. But we know by about 6 to 10 months of age, they start to lose that fetal hemoglobin and it gets replaced with their sickle hemoglobin. So in between that mark of 6 months to 10 months is probably the first time you can see a pain episode in a baby with sickle cell disease.
So there's a question about, does a person with sickle cell trait require hematology consult prior to surgery? And the answer is no. No need for hematology consult prior to surgery, because remember, those with sickle cell trait have 50% sickle, 50% normal. And at this level, they actually do not have any disease. People who are carriers of the sickle trait are very healthy.
So the answer is yes. So those babies that are under 6 months of age and experience pain, we'd obviously only be using acetaminophen at home. For the older babies over 6 months of age, we can use acetaminophen and ibuprofen. We generally don't give morphine prescriptions for the babies to have at home. We would want them to come to hospital to get their first dose of morphine so that we can actually watch them and make sure that they're doing okay with it. But as the babies age, the same types of drugs would be used, just depending on their age.
So again, I wanted to thank our two guest speakers, thank the participants for your questions and your interaction as well. webinar it is being recorded, it will be archived and available on the RNAO website. And again, this was around really starting the conversation. And you can tell by the variety of questions that there's a real hunger in nurses for this knowledge and information. There are, training needs to improve, and we need to have more conversations about sickle cell disease. And it's really good to get the conversation started, to start to think about within your clinical practice setting, what are the key issues for you? Where do you want to go with this? And how can you engage other nurses and build on what we started today? Thank you, everyone.